clients generally in the 3 states that I've worked, and I'm not going to say this is everywhere, when they go into jail, they are taken off all medication. And the only way they get put back on medication is if they are not manageable in the population. Now, I could go off on a whole tangent about that, and I will refrain for right now. But that means if they are on medication-assisted therapies for addictions, the thought is going to be, well, they can't get the substance in here. They don't need these. Cut them off cold turkey. And that can get really ugly if they're on methadone or anything else. And if they're incarcerated, they're not going to be able to get the medications if you happen to work in a jail. And finally, what is their motivation? Are they willing to actually do the work so the medication-assisted therapy can be successful? Because it only does part of it. You know, the person, medication-assisted therapy is only the walking sticks. They have to use their own feet to move up the hill. So we need to know, are you willing to do the counseling to address the issues and make behavior and lifestyle changes to address the issues that made you want to use? Stigmatization, why people may not want to use medication-assisted therapy. There are a lot of places, many 12-step groups, many treatment programs that are very, very opposed to medication-assisted therapy, with the exception of, interestingly enough, nicotine replacement therapy. So we want to look at the science versus the dogma, and the science is really supportive of MAT in short to moderate term. And like I said, we're talking 6 months to maybe 5 or 6 years. After that, you know, it gets questionable about whether there's any effect. So we want to look at whether we're using it, and we also want to look at whether we're using the medication-assisted therapies in an evidence-based way, or we're just handing it out as a alternative to street drug use. And that's not helpful. That's not medication-assisted therapy. That's just peddling. Like I said, 12-step groups are generally pretty against it, very vehemently against methadone and Suboxone. Less opposed, but still somewhat opposed to some of the antidepressants and things that are prescribed, whether it's for mental health issues or to reduce cravings. I found a lot of resistance in 12-step programs. Methadone Anonymous is an alternative in some places, though, and it's really hard to find an MA group. But if you can, then that's wonderful. Not all counselors are open to medication-assisted therapy, so people may have to shop around to find a counselor who can understand the purpose and embrace the use of it. Like I said, there's a lot of counselors out there, especially since you can get Suboxone from your physician, well, from a physician on an outpatient basis. There are a lot of counselors seeing clients for mental health reasons, and those clients are on Suboxone or buprenorphine, and maybe even some on methadone, but methadone clinics have their own counseling program. So even as an L MHC or an LPC or a psychologist, it's important to understand what these meds do and why a patient might be on them. Most payers, interestingly, require that medication-assisted therapy be considered when available. So that actually shouldn't be on the barriers slide. They're usually pretty open to paying for medication-assisted therapy as long as it's FDA-approved for that reason. The hiccup that I found or that I've experienced was when we were trying to get Medicaid to pay for Vivitrol injections for alcohol abuse. So you want to check with the insurance company, but a lot of times insurance companies are on board with medication-assisted therapy. So what's the endpoint? Like I said, it's not forever. If you want somebody to stay on methadone forever, you actually have to get a waiver from the state pharmacy board or some state board in order to continue to prescribe after a certain point. The goal is stabilization. Now, somebody who has mild depression and was abusing drugs for 5 years, may stabilize a lot sooner than somebody who has schizophrenia, bipolar disorder, and was using and homeless for 25 years. So this is why we say there's kind of a wide range of what stabilization is, but we want to see them at the point where they're not going to relapse. This treatment is individualized. So, what it could be for one person is 6 months, another person is 26 months. It does allow for relapse. And what do I mean by that? I mean that medication-assisted therapy, in most cases, sometimes it's up to the psychiatrist, but in most cases, medication-assisted therapy says, all right, you were on this and you relapsed. Let's look at your dosage. Let's look at what happened. If you come back in and you say, I relapsed. Now, if you relapse and you continue to use, or you start using other drugs, now that's a big no-no. If you drop dirty for cocaine at a methadone program, you're probably going to be discharged. But if you relapse on heroin or fentanyl or whatever your drug of choice was, the doctor is likely going to look at it and go, okay, let's see what's going on here that would have precipitated this. So on to our meds. Smoking cessation pharmacotherapy comes in patches, gums, lozenges, and sprays. The antidepressant Zyban has been shown to be effective for smoking cessation, and varenicline or Chantix has also been found to be somewhat effective. Now, really quickly, agonists are those drugs that they take that have roughly the same effect as the street drug they were taking or the nicotine. Partial agonists are drugs that they can take, or medication-assisted therapies they can take, that activate those same neurons that, in this case, the nicotine does, but only activates it a little bit more than halfway, about 60%. So instead of getting a wahoo, they're getting a okay. But it helps take the edge off, so they're not feeling whatever this was down here. They're up at a level where it's tolerable. So partial agonists have been shown to be very effective. NRTs should always be combined with a behavioral therapy program. They've shown in the research over and over and over again that just replacing it is simply switching the method of access in many cases. We need to look at two things with nicotine. One, why were they using? Let's address those neurotransmitter imbalances and the stressors, physical, cognitive, emotional, that were causing those neurotransmitter imbalances. But also, we need to address the habit, because when people use, especially cigarettes, there's a lot of ritual to it. My mother was a multiple pack a day smoker. She would get up in the morning, roll out of bed. Before she even had her feet on the ground, she was lighting up her first cigarette, and she chain smoked throughout the day. It wasn't a, do I need a cigarette right now? It was, I'm conscious, I need to be smoking. And for her, as she went through and stopped smoking, part of it was to start addressing some of those habits. Now she's on nicotine replacement therapy, but I see that in many cases, there's still a lot of habit to it. Harm reduction here, I'm okay with it. She's okay with it. So, whatever. But behavior therapy addresses the habits and helps people break that, either the hand-to-mouth habit or the I'm driving the car, so I have to have a cigarette habit. Helps them learn distress tolerance, surfing urges, all that kind of stuff. Nicotine replacement therapy is expensive, and expensive depends on the person, but even the generics, it's like $16 for a box of the gum. So it's not inexpensive. Many states cover this through the Medicaid program. So if somebody's on Medicaid, they might be covered. I didn't finish my thought there. You also want to look for smoking cessation programs in your state. Many state smoking cessation programs have free access or significantly discounted access to the NRTs. Many state government employees also qualify for free or extremely low-cost NRTs. NRTs reduce the harmful effects of tobacco smoking. They haven't been shown to be anywhere near as useful with people who dip. And patients should not smoke while using. It actually could precipitate a heart attack, so let's not do it. The nicotine patch has the highest success rate of available pharmacotherapies, partly, in my opinion, because it scares the snot out of them if they know that if they smoke, they might have a heart attack. I've worked with clients before in other situations and other settings. I have one client that I remember distinctly, bless his heart. He was very low cognitive functioning, schizophrenic, but just the sweetheart. And he relapsed on cocaine. And I remember sitting in the nurse's office and I was talking to him and I'm like, John, I'm really worried about you because the medications you're on, when you're using cocaine, that could really be really dangerous. He goes, oh, don't worry, Miss Dawn. I stopped using my medications about 3 days before I went out and used because I didn't want to die. Okay. I'm glad he didn't want to die, and I'm glad he had that kind of forethought. But so the addictive mind will work in mysterious ways. With the patch, if it's on there, it's kind of on there. Granted, it's helping, it's transdermal, it's kind of steady state, whatever. But I think there's also a certain amount of fear that goes along with that. The gums require a correct chewing technique. You're not supposed to chew it like regular gum. And they tell you to chew regularly for the first month and then taper off over 6 months. They've found that people who chew a piece of gum every 2 to 4 hours, and I don't remember what the number was, instead of waiting till there was a craving, had a higher success rate than those people who waited for a craving. And the drinking coffee or acidic drinks while you're chewing the gum reduces the absorption of the nicotine. So there's a lot of things to consider with the gum. Are you able to not drink coffee? I know that would be a big deal for me. Is this going to work for you? With the gum, it's easy to kind of forego it and go, you know what, I'll have a cigarette instead. So they have to be super motivated. Lozenges, suck on, move it to the side till it dissolves. There's no comparison studies of the effectiveness of lozenges versus the patch or the gum, but some people prefer that if they've got, like I do, TMJ. I can't chew gum, so the lozenge might be effective, but the nasal spray also might be. It mimics the pleasurable effects of nicotine and has the highest risk for abuse. If you're working with someone, and I do want you to consider this, if you're working with somebody who used to or continues to self-administer other kinds of illicit drugs through inhalation, nasal spray is probably not a good way to go because that can be an easy trigger for relapse for other things. The spray can only be used for up to 3 months. So there are options for people if they're motivated to try to get off nicotine. Part of it is what they believe is going to work for them and what won't trigger other problems. Zyban is, again, an antidepressant. It works on the dopamine and norepinephrine receptors to decrease withdrawal symptoms. They say this needs to be started about 2 weeks before the quit date, and then you kind of taper down to you take it daily for 3 days. You can continue the pills for 8 to 12 weeks, so you're not going to be taking it forever. Side effects, it could cause insomnia, not so bad. Anxiety, not so great. Or seizures, gives me pause, but depends on the person. If they're not at risk for seizures and if they've got concurrent depression, this might be helpful for them. The prescription includes a behavioral program to go with it. Chantix is a nicotine partial agonist. So Chantix is one of those that goes in and stimulates those receptors enough, but not all the way. Again, this is one you start before the quit date. You increase your dose, and it can be taken for 12 to 24 weeks and includes a behavioral program. One thing they found with smoking is that people who are in recovery from abuse of other substances are at a much greater risk of relapse if they continue smoking. One theory is because they are using a drug to moderate their moods through the nicotine, and it serves as sort of a gateway drug. But pharmacotherapy for alcohol dependence, antabuse, Camprol, and Vivitrol. Antabuse blocks acetaldehyde dehydrogenase. Basically, it keeps enough alcohol in the system that you actually start suffering alcohol poisoning, and it makes you vomit. The reaction is flushing, palpitations, chest tightness, nausea, anxiety, and headache if you drink while you're on this. It does help people avoid slips or relapses, but I do know addicts who've taken it, and just to see how bad the effect would be when they got it, they intentionally went out and started drinking just to see how much they could drink and how bad it would be if they actually relapsed again. So we want to look for somebody who's motivated. It will affect the liver even without alcohol and has a ton of drug interactions. So motivation is really necessary for a patient on antabuse. Camprol, or acamprosate, helps address the GABA and NMDA receptors in the brain, which can lead to alcohol dependency. Remember, GABA is your natural anti-anxiety, and NMDA is responsible for learning and a lot of other things. It's also involved in the stress fight or flight response. So Camprol normalizes GABA and glutamate in the brain, keeps that bath warm because GABA is made from glutamate. It doesn't have any drug interactions to note, minimal side effects, and it can reduce the symptoms of protracted withdrawal. So after somebody gets off detox, they may have some ongoing foggy head, post-acute withdrawal symptoms. Camprol has been shown to help with that, but you want to use caution with it in suicidal patients. And Revia blocks opioid receptors and pleasurable feelings from alcohol. This is naltrexone, and we're going to talk about it on the next slide as Vivitrol. Reduces craving. It comes in tablets or implantable pellets. Reduces alcohol slips and can be used for opioids and alcohol. Now, it's blocking those opioid receptors. So when somebody drinks, they drink and they're just like, what was that? Which can be okay. Vivitrol is an intramuscular injection of naltrexone, which is given monthly. The nice thing is it has to be done in a doctor's office, but it's only once a month dosing. It was recently approved for alcohol, and but also requires patient motivation. Maintenance therapy for opioids, and long-acting medication in a controlled setting is what we're looking at, because we know that we want to make sure that people don't relapse, because relapse on opioids is way deadlier in many cases than relapse on pretty much any other drug. Helps avoid withdrawal and craving, reduces disease and crime, and we want to look at it in terms of maintenance or detoxification. So are we looking at it for an 18-month step down so they don't have withdrawal symptoms from the heroin, or are they going to be on it for a couple of years while they learn other skills? And yeah, 18 months step down from heroin is not unheard of. 18 months step down from methadone is also not unheard of. Methadone is a full agonist. It's opioid substitution therapy. Highly regulated. It has to be licensed, has to be in a specific program. You can't just get it at your doctor's office. Patients are regularly drug tested, and treatment programs are required to provide counseling. Now, these are going out pretty quickly. I don't know if they're going to come back, so I'm not going to spend a lot of time on them. But just so you know, and you can go back and look at this a little bit more closely later if you're interested, but there are phases in opioid treatment, methadone treatment. Initially, they have to come in 7 days a week to get their meds. Over the period of a year, they start getting to the point where they can get up to 3 take-home doses per week. So they're still having to come in 4 days a week. After 3 years in treatment, they may be eligible for 6 take-homes per week, so they have to come in once a week, provided that all of their drug screens for the past year have been negative. So there's a lot of drug testing, a lot of counseling, but in order to make it available and reduce diversion and everything, all of these regulations have to be in place. Controlled trials comparing medication and placebo show the superiority of agonist, that full-scale methadone pharmacotherapy. Improved treatment retention, eliminates the use of non-prescribed opioids because they're not feeling the cravings. Decreased criminal activity, reduced spread of HIV, with pretty good results. Reduced mortality, improved health, and improved psychosocial functioning. But can you get all of these from other drugs? Do we have to do a full opioid agonist? Not necessarily. But methadone does not get you high. Because of its longer half-life, methadone suppresses withdrawal and drug cravings for 24 to 36 hours. At prescription doses, now if you take 3 doses of methadone, yeah, you're probably going to feel pretty darn good or die. But there's no real euphoria for people who are on methadone maintenance. Once they get used to it, it causes sedation, but not so much that they can't work or drive safely once they've kind of developed a tolerance and they're on a good dose. It is deadly if it's mixed with any kind of depressant, including benzos and alcohol. Cognitive impairment may occur during induction or a change in dose or in combination with other drugs or medications, including over-the-counter. But like I said, once they get used to it, it's totally safe. Some states restrict the amount of time people can be on methadone. They need to be evaluated periodically to see if they can come off. One of the benefits of methadone is for people who either are refusing to get off heroin or street opiates the hard way. They want a kinder, gentler detox, or they can't imagine living without something. So this kind of helps them. But so do buprenorphine and Suboxone. Buprenorphine is an alternative to methadone. It's a long-acting opioid agonist-antagonist. It has a ceiling. It's only going to get you so far and then not so much. So again, like the other partial agonist, it gets you from to okay, but not all the way up to woohoo. Multiple forms. It can be combined with naloxone, which is called Suboxone. Buprenorphine only is called Subutex. And when it's used for treatment of acute pain, it can be called Buprenex. It binds to opioid receptors in the body and only activates them about 40%. If somebody's already in withdrawal from opioids, then activating those receptors 40% is pretty good. It's going to take them from feeling like they've got a really bad case of the flu to, okay, I can survive the day. If they're not in withdrawal, then dropping from 100% to 40% is going to make them feel pretty crappy. So it's up to the doctor and the patient how they transition. Buprenorphine is less restricted than methadone. You can get it from a pharmacy with refills for up to 6 months, but outpatient physician visits for medication checks are needed. Addiction counseling is separate, and a patient may be referred to another provider for this service, again, because it's an outpatient thing like Suboxone. So we're going to skip over that and move on to Suboxone in the interest of time. Combination buprenorphine and naloxone. They put those two together so that if somebody decides to either to try to inhale it or inject it, the naloxone kicks in and it triggers an opiate withdrawal right away. So you're not going to do that. The short-term desirable effects of Suboxone are a pain-relieving effect that's between 20 and 30 times more powerful than morphine, and a mild euphoria that lasts for around 8 hours. A sense of calm and inflated well-being, a perception of fewer worries and lower stress, and increased relaxation. It can be abused by individuals addicted to short-acting opioids like heroin because they'll use it between doses to keep withdrawal symptoms from occurring. It can also be abused by other people who are doubling up, taking 2 or 3 Suboxone at a time. The naloxone only kicks in if the Suboxone is ulcered and injected or snorted. If a person who is not already tolerant to opiates uses Suboxone, the effect produces a mellow high, but it's evidently a pretty pleasant feeling. Final thoughts. Like any other opioid, tolerance develops quickly and goes away quickly. There's a danger of overdose in patients who've tapered or stopped using opiate agonists who relapse, because they often relapse expecting to be able to use as much as they were using before they stopped, and that's not the case. Because of that, Narcan, which is the opiate reversal, is available in 35 states at Walgreens and some other pharmacies, but is available without a prescription. And yes, Suboxone can be put on stamps. It can be put on anything that can be licked. So it is the preferred drug in many correctional institutions. Urine drug screening needs to be incorporated into all medication-assisted therapy in order to help people stay safe, make sure that the medication-assisted therapy is doing its job, and help us figure out what else we need to do. If the person is relapsing, obviously we're missing something, and we don't want to just put them in a situation where they're still in danger, they're still suffering. Long-term pharmacotherapy is available and effective for several addictive substances. Medication plus counseling equals recovery. Medication alone won't do it, and for some patients, that period of time until their neurotransmitters stabilize and they can see colors again and they can feel feelings is so oppressive that without some sort of stabilizing pharmacotherapy, counseling alone may not be enough. So we need to consider the client. Nicotine replacement is available over the counter. Bupropion and Chantix are available by prescription for smoking cessation. Multiple medications are available by prescription for alcohol dependence, including antabuse and Vivitrol. Methadone buprenorphine maintenance has been proven to reduce mortality, crime, and the spread of infection. Substitution therapy to eliminate withdrawal cravings and heroin effects. So we're really using either a full or a partial opiate agonist in order to help people feel some of the benefits, to address some of the reasons, if you will, that they started using the illicit substance in the first place. All of these require an individualized dose because people are going to have different tolerances to opiates. We are so excited to announce the launch of DocSnipes.com and its associated podcast, Happiness Isn't Brain Surgery. These resources are designed to provide practical tools and information to help people start living happier. DocSnipes.com contains solution-focused goal sheets, what we often call treatment plans, videos, informational texts, workbooks, and a variety of other resources that clients can use to enhance their counseling experience. Unlike other sites that just provide the worksheets, DocSnipes.com provides text and video resources to walk people through using the tools. The resources are ready-made for you, saving you, the clinician, loads of time and freeing you up to do the actual counseling work. During the first half of 2017, we're offering introductory memberships for $5 per month. Lock in your rate now. Annual memberships are also available at a discounted rate for organizations if you would like to use our resources with your clients but don't want to have them subscribe individually. Contact support at DocSnipes.com for pricing. Go to DocSnipes.com to learn more, and join us each week for the Facebook Live broadcast and recording of the podcast at DocSnipes.com/Facebook. If you enjoy this podcast, please like and subscribe either in your podcast player or on YouTube. You can attend and participate in our live webinars with Dr. Snipes by subscribing at allceus.com/counselor toolbox. This episode has been brought to you in part by allceus.com, providing 24/7 multimedia continuing education and pre-certification training to counselors, therapists, and nurses since 2006. Use coupon code Counselor Toolbox to get a 20% discount off your order this month.